not very good. So prognosis wise also it from 74% to 35%. In our report, if there is extramural vascular invasion, you have to pick it up. Classical exam case, I'm expecting that the examiner will show you extramural vascular invasion just to check your concept on that. Another thing before I continue is to see this tumor. You know, we use a word, we call it intermediate signal on T2 weighted sequence. Classical tumors are like this, intermediate signal on T2 weighted sequence. They are not very high signal, they are not very low signal. So if I go back and I just showed you that metastasis, ovarian metastasis sitting on the rectosigmoid, and look at this signal, this is intermediate signal on T2. When you will cover, you know, gynae tumors as in CS cervix, etc., you will realize that this will be the signal. So now this is how we should report an MR of the rectum. First of all, what is the distance from the anal verge? Now, please remember that this thing, the surgeons should tell you actually that this is the distance from the anal verge. Having said that, you can also sort of infer it on the imaging. Then you have to say what is the craniocaudal and the transverse extension. The transverse extension is also what we call the depth of the tumor. So how thick is the tumor or how deep it is, it has got some prognostic value there. Is it going into the mesorectal fat or not? For me, this is a classical exam case, and what we are expecting for you to be shown is this thing, extension into the mesorectal fat. Now, from here comes this concept of distance from the mesorectal fascia. Now, if the tumor touches the mesorectal fascia, then we use the word it is circumferential resection margin positive. You know, the basic concept is that in surgery, what they do is they just remove whole of the rectum, including the mesorectal fascia. So the mesorectal fascia, mesorectal fat, and the rectum comes out of it. When it goes for histology, the histologist will say that was the circumferential resection margin positive or not. If it is positive, means bad news, because you don't know if it has gone beyond it. If it is negative, it is good news. Similarly, these terminologies can also be used in pre-operative MRs. And the concept is that if the tumor is as close as 1 millimeter from the mesorectal fascia, we can use this word circumferential resection margin positive. And if it is more than 1 millimeter away, then we call it circumferential resection margin negative. Many people do not use these words, but they just report it. They say that the tumor is abutting the mesorectal fascia, for example, or say that it is only 1 millimeter from the mesorectal fascia. Now, any pelvic organ involvement, you know, if it is a T4 tumor, then you have to say that, you know, it is going into the lateral pelvic wall or whatever. Are there any mesorectal nodes? You have to tell this. Is there extramural venous invasion? Are there any pelvic nodes? So mesorectal nodes are, of course, around the rectum, within the mesorectal fat, and other nodes are, you know, other chains like obturator chain and external iliac or internal iliac chain, etc. Now, in Atomy, I have already told you that you have to have clear-cut idea of where is the peritoneal reflection, and in a male, this is the seminal vesicle. This thing goes here. So from here downwards is only the mesorectal. from the junction. That is pressure. And a better idea is to use a criteria where a lymph node if it has got slightly heterogeneous, would like to call it abnormal. So these are the criteria to or the things which you have to answer in the exam. The chapter. So I'm going to show you case in a what type of format.
Yes, I can.
Okay, so this is a case of T3 tumor in a case which is 51-year-old male. So I am showing you an axial slice here, and I want you to see it with me. Now, on this axial slice, this is, of course, the bladder. This is the seminal vesicle. And you can see that this is the mesorectal fascia. And this is your tumor. Now, you can see till now, so I'm more distal. You can see actually the prostate here. And here, if you see the wall of the rectum becomes looks normal. And then as I'm going superiorly, you can see that the wall becomes thickened. And now and you will appreciate that this signal, actually, this is more or less a circumferential tumor. It is, it is a 360-degree type of tumor. If just on this slice, if you see here, and develop your eyes on this one, look at this. We call it whiskering. You see, where I am pointing out, this will be the muscularis. So something is going out. If I just show you this slide, you can be confident enough of saying that there is whiskering and the tumor is in continuity with the tumor here. So it is going into the mesorectal fat. And with that, you can see this. Look at this structure. It is just like a vessel. Look here, it is just like a vessel. So these two are intramural venous vascular invasion. But the same thing here. For example, there is another vessel which is, and same thing here, same thing here. Now, if you look carefully, this is the mesorectal fascia, and this tumor here is abutting it. And even here it is abutting it. So I will say that this is a, just on this point, this is circumferential resection margin positive. Now look at the lymph node. This is one lymph node. in the presacral space. Look at the signal intensity. Where I am pointing out, the signal is slightly intermediate, and here it